Now we'll have Dr. Purendra BHASIN talking about toric IOLs, an elegant way to control astigmatism. Dr. Purendra.
Thank you, Dr. Ashu, for giving me this opportunity in your course. And friends, um, toric IOL is one of the definitely one of the best and elegant way of correcting the astigmatism, and this is one of the most established way. And before taking it further, I will give you the importance of correcting the astigmatism. If only a 0.05 diopter of astigmatism is left over, it can decrease the vision to 6.9 or 6.6 part, and and now the cataract surgery has become a refractive surgery. So most of the patients, they are very demanding, and 6.9 6.12 vision, and with 0.75 diopters you can have 6.12 vision, and with one diopter, 6.18, or even 1.5 diopter, 6.24 vision. So visual outcome with toric IOL, various studies have been there, and they have all proved it to be the best, and there is a better visual acuity, less post-op refractive astigmatism, high ratings for clarity of vision, greater spectacle independence for distance, high patient satisfaction with toric IOLs. So all the studies have proven till now. The scope of my talk today will be on the pre-operative assessment, intraoperative pulse, and the post-operative correction of the surprises post after this surgery. The patient selection is one of the most important thing, and we should understand the patient's expectations, why the patient has come, for what patient has come to us, and proper counseling has to be done, and we should tell them that we are targeting 100%, but the technique is there, and we may land up a little less or so. And a careful patient examination is very important. We should treat epithelial Bowman's membrane dystrophy and other treatable basement membrane dystrophy and other treatable corneal irregularity before the surgery. We should treat surface disorders, meibomian glass disorders before taking patient for surgery, because this can lead to erroneous calculation of the axis and the magnitude of the astigmatism. We should look for any corneal dystrophy, Salzmann nodule, scars, presence of RK marks, PRK, LASIK, and a accurate preoperative testing of cylindrical power and axis is very important. And we should not rely on one reading. Treat only the corneal astigmatism. I remember one patient came to me for the for the refractive surgery, and she was young, around 30 years old, and she was advised refractive surgery elsewhere, and she came to me. When I saw the patient and we did the topography, we found that the corneal astigmatism was minimal. Then when we dilated and saw the patient, there was a subluxation of the lens which was inducing 2.5 diopters of the astigmatism in that particular case. So we have to treat only the corneal astigmatism, and I recommend toric IOL in cases of all cases of astigmatism more than one diopter. A potential candidate for toric IOL would have regular, symmetrical corneal astigmatism, and we should not treat patients with irregular astigmatism, cases of keratoconus like or any other ectatic disorders, and they will not improve with toric IOL unless until they have been cross-linked, or it may worsen if there is a high irregularity. So, there are three steps for toric IOL implantation. First is accurate preoperative testing of cylindrical power and its axis, marking the axis on the eye preoperatively and intraoperatively. This could be done by digital marker or a manual method, and then intraoperative alignment of the IOL into the desired axis. And any error in any of the steps will lead to poor results or residual astigmatism. So coming to the first step, that is preoperative planning and calculation and marking. To perform keratometry and make sure there is a corneal astigmatism, perform topography to evaluate, to find out the location of the steep meridian and the axis, and it will tell us if the astigmatism, whether the astigmatism is regular, It will further give us the idea whether the astigmatism is symmetrical or asymmetrical, and to some extent it will help us in to evaluate dry eye also. Then coming to the step 3, perform a posterior corneal measurement with the pentacam or Galilei, and this is also very very important. So we should use the magnitude of astigmatism of a manual or a automated keratometer. You take into consideration that is very much reliable, the magnitude or the number of astigmatism, the power of astigmatism which we are getting with the manual or automated keratometer, and it should be rechecked by IOL master and lens star. What my personal observation is that IOL master and lens star, they give us slightly higher reading, and we should err on the lower side and compare with axis derived from topography or pentacam. And this axis which we get from the pentacam or the topographer, that we can check it with our manual or automated K and IOL master and compare it, and it should not be much of difference between all three. And before moving ahead, we must confirm it with multiple measurements and never take into consideration what the patient refractive correction is, what the refractive astigmatism, refractive axis, the subjective power of the patient, that should not be taken into consideration. So when results from two instruments do not agree at the axis and magnitude of astigmatism, if reading from manual K and pentacam are not within 10 degree, then repeat both after calling patient again. Maybe you, some the there may be the dry eye, or you must have put the dilating drop, all these, and lubricating drop, and if you have done applanation tonometry, all this can do give change, give rise to change in the magnitude and axis of the astigmatism. So we can call the patient again after some time and repeat the patient with the power again. For 1 to 1.25 diopters of with the rule astigmatism, we may use on-axis incisions rather than a toric IOL. And because I have seen that if it is against the rule astigmatism of one diopter, then we correct. If it is one diopters of with the rule astigmatism, the non-axis incision will help, and we don't require toric IOL by and large. Coming to the posterior corneal curvature, posterior cornea is a vertically steep in about 87% of the eyes. This causes a net against the rule astigmatism, as back cornea is a concave or a minus lens and causes opposite effect. This results in an overcorrection of with the rule astigmatism by 0.050 diopter and undercorrection of against the rule astigmatism by 3.3 diopter. So one should keep into mind that we should slightly undercorrect the with the rule astigmatism and overcorrect the against the rule astigmatism by zero point 0.3 diopters or so, and undercorrect by zero point 0.5 diopters of the with the rule astigmatism. Ideally, one is to use the accurately measured posterior corneal astigmatism by pentacam or Galilei, which are the Scheimpflug imaging systems. And another important thing is to know about your surgically induced astigmatism. And this will depend on the incision length, patient variability is there, incision location, whether you are close to the visual axis and how far you are towards from the visual axis, and there could be a measurement variability. So the best way to calculate the surgically induced astigmatism of a doctor, that we can enter some 50 to 100 cases in a sia.calculator.com, this thing website. You can go there and check it and enter your last data of 100 patients or 50 patients and get the average of it. It will tell you whether it is 0.30, 0.20, 0.50 is the surgical, and your incision length should remain the same. And another one is from Dr. Sahani also. That also gives us the SIA. And now coming to the formula, what formula we should use? So as on date, various formulas are available to us, but the Barrett toric calculator formula has shown its superiority in majority of the patients, and I am using that only in all my patients. But other formulas are also available. In extreme of the myopia or hyperopia, you have to be very, very careful and be very, very selective in doing such cases. Now coming to step 2, after determining what your magnitude and excess of astigmatism you are going to correct, and you have placed an order to the company, you have finalized the lens, and now on the day of surgery, you have to mark the patient pre-operatively if you don't have a automated or digital marker system. So when you are doing a manual marking, you can use either a free hand on the slit lamp, as you can see, and the patient has to keep her head, or patient's head should be vertical, and that is very, very important, and forehead should touch the band of the slit lamp, and patient should look straight into, and the eyes should be wide open. In this particular case, I am marking 180 degree with a free hand in my left eye, with my left hand, and the patient on the patient's right eye, and as you can see, these are the marks. uh, Earlier I used to mark at three places. These three dots are there, which are done by freehand marking. Now I do it, which were at 0, 180 degree and 90 degree. Now with two marks also, like at 0 degree or 180 degree on right eye or left eye, and one at 90 degree, you can go away. And the other on the right side of your picture is the bubble marker. This is a small video how you can mark on with a bubble marker. So there is a bubble in this green cylinder there, and which has to be this bubble should be within the two lines, and this is the mark which you are going to get. Electronic preoperative marker are also there, and digital marking system is from Alcon. It comes from by Varion, and with from Zeiss it is by Callisto system. There also you have to register the patient preoperatively, and this helps. This works on the principle of registering the scleral conjunctival vessels and the iris pattern. So in the operation room, there are 7 pearls which should be taken into consideration. Corneal marking should be done, and which what is the incision location, that has to be marked before. We should be very, very careful in the size of the capsular axis. It should not be too small, it should not be too large, it should cover 0.5 millimeter of the optic of the lens, and position IOL short of intended axis of implantation by 30 degree. And then after once you have implanted, you have removed the viscoelastic from behind, you can rotate the IOL. OBD removal under the IOL is very important. Tap IOL to fixate to the capsule, and final IOP should be in the low or mid teens. It should not be overfilled, otherwise the lens can rotate in the immediate postoperative period. And finally, before removing the speculum, you should check it whether it is fine, aligned with the desired axis. Now this is the sheet which comes from the company, and this is from Alcon company. This is a patient where the power of the cylinder is 3.22 diopters, and it is at 94 degree, which is the preoperative cylinder. And then the lens which has been ordered is at 25 diopters, with cylinder to correct cylinder of 3.75 diopters at 95 degree, and this is the 95 degree is the axis of implantation or alignment, and this is the model of the lens T6 with the residual astigmatism of 0.16, which is intended after the surgery, and with the 0.23 diopters of residual spherical power. So this is the surgery, and which is by the help of a Varion system, and this is a manual capsular axis, and after the polishing of the capsule completely, uh, the lens is injected, uh, and I'm doing using a hydro this thing system, irrigating system, and I'm not used in this particular case viscoelastic, but one may use. I will prefer that we should use viscoelastic. Now we are aligning the lens at 90 degree, 95 degree. This is the intended axis, the green one, as you can see, and uh, our 180 degree or 0 degree was the incision location. So this is how the lens is covered all around by the capsular axis margin, and it is very well aligned at the end of the surgery. And I am doing hydro. The wound is hydrated. Another case, which is toric IOL, axis of placement here is 170 degree, and the cylindrical power is 3 diopters, and at the corneal plane it is 2 diopters, and the incision location is 60 degree, as you can see in the bottom. So this is the surgery. So first we have to align with the Mendel's marker. A 60-degree mark is done. Incision for the incision location, a diamond blade, and capsular axis, adequate size capsular axis is made. And after doing phacoemulsification, IOL is the loaded in the cartridge. And now the lens is then aligned. This is in the presence of the methyl cellulose, and remove the viscoelastic from under the lens, from anterior part of in the from the anterior chamber, and align the lens with the axis of intended axis of implantation, which was 170 degree. So this is how it is done, and wound is hydrated. So this is the case, which is very well aligned, as you can see here at the end of the surgery. The top consideration in success of toric IOL prediction is the use of topographer, and use of keratometer biometer to calculate power difference between the principal meridian. Include posterior corneal astigmatism in calculation by using an advanced calculator to avoid any surprises. Optimize the SIA, surgically induced astigmatism. Consider whether overcorrection to with the rule astigmatism is warranted for patients with against the rule and oblique astigmatism. Try no visco IOL implantation for better results. Now, coming to the residual astigmatism, which could be due to the incorrect IOL power calculation, or we have not taken into consideration the posterior corneal curvature, or there is a disaccordance in the cylindrical axis between various instruments, and still we have gone further without checking it again. Surgery didn't go your way, like poor creation of incision, or there is a large incision or irregular incision, or the lens part is one is in the bag and partly in the sulcus. Understanding we should understand the residual refractive error, whether it is spherical, whether it is cylindrical power or spherocylindrical. Check after dilation IOL axis on slit lamp, and placement of IOL to be checked whether there is a tilt in the lens or both haptics in the bag, or partly one haptic is in the sulcus, and there is chances of rotation of the lens. This is a case wherein the 23 diopter 2 diopter correcting trifocal toric was implanted, and patient's preoperative astigmatism is 1.5 diopters. So everything went fine. This is a plate haptic trifocal lens, toric lens, and axis of placement is 160 degree, and it is properly aligned, and the surgery went fine, as you can see here. Now, after a week, the patient immediate post-operative period. Next day, the patient vision was 6.9. After a week, patient came to us and he said that her vision has decreased to 6.24. Best corrective vision with the zero point 0.5 diopter plus zero point 0.5 diopter cylinder and 2.5 diopters cylindrical power was 6.9. So there was no other problem, but the lens has rotated, and this is what it is seen. Instead of in the 170 degree meridian, which is like at this, the lens has moved to a 90 degree. So what we have done is we have released the adhesions of the lens to the anterior and posterior capsule by with the hydro cannula, and then we dialed the lens at the desired again plane again. Maybe the in the immediate post-operative period she must have rubbed the eye, or maybe it was overfilled That may be the reason why the lens has tilted. So other way to get it checked is you can go to www.astigmatismfix.com and check it. The residual enter the pre-operative, the type of lens, and the model of lens to which you have used, and what is the residual refractive error and astigmatism, and the mod and the this will give us idea in which direction how much the lens has to be rotated. uh, Other options are we can correct the residual refractive error by LASIK or PRK if it was the erroneous IOL power due to the erroneous IOL power calculation. Erroneous IOL power calculation will lead to a spherical kind of as the residual refractive error mainly. Or we can go for LRI as has been described by Dr. Bharti here. To conclude, toric IOL for one diopter and above against the rule astigmatism, and with 1 to 1.25 diopters of with the rule astigmatism we should consider. One can use on axis a paired incision in place of toric IOL for one less than 1 diopters of astigmatism. Intrastromal limbal relaxing incision, arcuate incision by femtosecond laser or manually by diamond knife is a good option for less than 1 diopters of astigmatism. There is less dry eye, wound gap, and better predictability. Adding toric IOL to your surgical armamentarium is the most effective way to enter refractive cataract surgery. And believe me, I am very happy and satisfied. Even with 1 diopters of astigmatism, 1.25 diopters of astigmatism, I am getting very good visual outcome and good results. And in this era of refractive cataract surgery, when the patient is so demanding, and we are using multifocal, trifocal, and EDOF lenses or VBT lenses, we have to be very particular in giving because they are paying so high, so they in lieu of it they want a best quality distance and near vision. So toric lens is the way to go. Thank you.
Purendra said that for pre-existing astigmatism, toric IOLs have matured enough and are a very good way to go. Uh, Results are excellent because if you don't do it, then even the distance, unaided visual acuity, uncorrected visual acuity is not very good. And moreover, these lenses are very forgiving. The fear is that they'll rotate. Some of the good manufacturers, even if it does rotate by 5 to 10 degrees, the visual degradation is not so much, and the patient will still feel a lot of benefit. And so, as I say, they are very forgiving lenses. And of course, the fear is that one of the apprehensions if you're starting out is that it's relatively more expensive. What will the result be? The results will be good, rest assured. The question is, one is the expense of the lens and also the paraphernalia. So there are cheaper ways of doing it. Dr. Purendra talked about Varion. Dr. Saurav will be talking about some other imaging systems along with Varion. So those are, if you have them, they're great. I don't have them. Dr. Bharti also doesn't have them, I think. But so you can do without these imaging systems. Even corneal topography, if you can confirm with corneal topography, it's great. But if you don't, a simple, what companies recommended earlier was manual, but I would say manual still can have error. Some good auto refractometer, if you have the keratometry on that, if you do it carefully with a proper blink and making sure there are no dry spots, a very good keratometry can be there. And I've been doing it for so many years now, and I've never been let down by automated keratometry. Yeah, if you can confirm with topography, great. If you don't have a topographer, do not be dissuaded. Please attempt it. If you do not have the imaging systems, again, if you have them, great. If you don't be this thing that you cannot do it without them. Coming to marking, there are various systems that are
Yeah,
available now.
and the apps are also available now.
Apps are
That
available.
various apps are also available. You don't require this expensive Varion or Callisto system. You can go to the apps and pre-operative and calculation and intraoperative marking can be done with the help of those apps, and they are effective. And one more thing I would like to say is that uh, uh, the now some Indian lenses are also they are also reliable. Earlier we were depending on these imported lenses which were expensive. So everybody has an apprehension. So the Indian lenses are also now quite reliable
Yeah, so in
for the
case you're
astigmatism
a little
correction.
apprehensive, you can start with Indian lenses also. They're also giving good results. because you see, unlike multifocal, the toric has a definite advantage. Multifocal, there's a subjective issue. Some patients may be happy with it, some may not be happy. The design is very variable. In toric, it's a no-brainer. It's astigmatism which has been given at a certain axis, and that is likely to benefit. And coming to simple marking, also just a little tip. What I normally do is I make the patient sit on the slit lamp, probably put a wire speculum initially if you want. Maybe later on you don't even need to do that after putting a drop of paracaine, and ask the patient to look straight in a full beam with under visual impression. You ensure that you're bisecting imaginary line, bisecting the cornea into two halves, a superior inferior half, just a horizontal line, imagine that, and take a 26 gauge needle, ink it with the marker pen, and just place an impression on the 180 and 0 degrees. I mean, and that works very well even for any toric marking, for toric ICL, toric IOLs. This is what I try to do, and this really helps. And the impression is there, even if it goes away, the indentation due to the 26 gauge needle, the sharp needle, that stays. And even if the ink mark goes away, you'll still have it while you're on table if there's some transit time delay. So I think we'll go on to the next.
Sorry, I have a question for Dr. Punendra. Now, uh, like I might be very wrong, so I just want to ask that question. Is that there were, like, we were doing torics at one time, and there were various, there were imported torics at that time available. We used to calculate our toric according to the online calculators, and we used to get a result. Then came the concept of the posterior corneal astigmatism, and we started looking into it. Once we started looking into it, and we said that our results will become better, and they did become better because we started looking into it and we started incorporating it into our calculators. There were Boiler nomogram which we used to follow, and then after that came the Barrett's calculator. Now, what my experience, and as I said, I might be very wrong, was that if you calculate your PCA and incorporate it in a Barrett's calculator, you're actually correcting the posterior corneal astigmatism twice.
Yeah.
So now, with the newer calculators, you have to forget about the posterior corneal astigmatism. Like, as I said, that's what I understand, because I landed up with a few, that's my little experience, that there were a few cases in between which we calculated the PCA, we used it in the new calculators, that's the Barrett calculators, and we landed up with not so good results. So I hope I'm clear here, because
Yeah.
I might be wrong,
Yeah.
essence.
So with the newer toric calculator and newer IL master version 700, so we don't we do go as per the suggestion given by the Barrett calculator. We don't change it. But when, because for the general audience, when they are not having this access, so and they don't have, because corneal astigmatism correction is considered when it is done by the IL Master 700 only. Otherwise, it is to be done it. That's what I
No, you
feel.
can get the posterior aspect also with the Barrett online toric calculator. So you can just use that also. In fact,
That is
that's
all.
what I use.
That's what.
But
So
I think what
the
Saurabh is
question is
saying
not that
is,
you don't have to check the PCA now. You don't have to check the PCA, because if you
it's a
put it in a
presumed one.
Barrett,
It's a
because
presumed one.
Barrett's calculator is already taking that
Yes,
into
they're
account.
taking.
So it is not that you have to go to the Barrett PCA calculator.
No, no, no.
You don't have to. So you just have to put it in and just forget
Yes,
about
yeah,
the
yeah. So
posterior
there's a
corneas.
online Barrett toric calculator. So like Dr. Saurabh rightly said, do not calculate it first and then add it. So you don't have to do anything. What they've done is they've taken a lot of retrospective data and they've come to the conclusion that you just feed it in. And so basically the tip here is, if you have a with the rule astigmatism, the correction would be required would be lesser than, so you have one diopter with the rule astigmatism, the net would be about 0.88. 0.8 is the actual true astigmatism, corneal astigmatism. If you have against the rule astigmatism, that is the horizontal is steeper. If you have one, your likely true astigmatism is going to be 1.12. So therefore, I say, when you have against the rule, definitely do consider a toric IOL if it is significant enough. If you have with the rule, you know you can hope to get away with corneal incisions also. Let's say you have a 0.75 diopter of spheric, or even a 1 diopter of with the rule. I would attempt incision, because I know I can 0.25 will correct with my incision. 0.2, 0.1 to 0.2 will be corrected because of the posterior curvature. So I'll have a net result astigmatism of 0.55, 0.6. But if I have against the rule astigmatism of 1 diopter, I know I'll need to correct at least 1.1 to 1.2. So therefore, which is practically impossible with incisions. And as we know, the temporal incisions give lesser correction. So therefore, when you have against the rule, it is important to go with a toric IOL.
So what the current trend is that even if you have to make a LRI or whatever you're planning, besides the toric, you put it on the toric calculator and you'll have the exact amount of, if you need a LRI or if you need a, so if the results are coming as a T2, you can actually use a, and it does pretty well like that. But Dr. Purendra, one more question. You showed a video in which the IOL had rotated and it was a plate haptic IOL. I've had a few experiences which were not great with the plate haptic IOL and I've stopped using them. Are you still using them?
No, I now use because that material is hydrophilic and it is a plate haptic. So I now use a hydrophobic IOL because during those days trifocal lenses were not
No,
available
but the
with
plate haptic,
hydrophobic platform.
Yes.
but a plate haptic, which is the hybrid platform, not the hydrophobic total.
It is
The hybrid platform, are you very happy with those or?
uh, otherwise it was good, but rest of the things were good and many
So
people are still using.
yeah, so I know a lot of people are using it, but what I have experienced is that the plate haptic, the hybrid lenses from the particular company, they're slightly rigid. So if you put the leading haptics into the bag, and if you cannot put the trailing haptics in one go, and you have to use a Sinsky, then it becomes slightly difficult to put it in, and I've had a zonular dialysis in that case. So I have stopped using all plate haptic oils, so that's just my experience there, which I'll say.
The other reason is that there is a high incidence of PCO also
PCO,
with
yeah.
such these lenses. So now I'm 90% of 99% of our hydrophobic acrylic one.
Yeah. So
Rarely
we all use those trifocal lenses, hydrophilic plate trifocal lenses. But I think